The Education Committee thoughtfully wanted to focus our keynote session on maternal health, as this is an emerging area of research with enormous impact on both mothers and children, and encompasses a large component of the social behavioral determinants of precision health that Dean Miner has really focused as one of the key issues of the medical center. And one of the key global leaders in this area is Dr. Kelle Moley, who's currently the Deputy Director in Reproductive Health Technologies at the Bill and Melinda Gates Foundation. Dr. Moley is a native of Connecticut, earned her bachelor's degree from Wellesley College and medical degree from Yale, with residency in OBGYN at WashU, where she stayed on and worked her way up as a faculty member to become the Crane Professor of Obstetrics and Gynecology, running a NIH-funded research lab with appointments in cell and physiology. And she became a member and elected to the National Academy of Medicine in 2014. But then, seeing that she wanted to take a broader step to broaden her impact, she then took on the job as Chief Scientific Officer of March of Dimes, leading the strategic direction and oversight of the March of Dimes research centers, headed about 6 of them, headed including one at Stanford, headed by David Stevenson. Last year, seeing that she would have a better chance of impact, she moved to the Gates Foundation that this year will give out $7 billion in research funding to increase her impact in reproductive health. She notes that of the 1,600 employees at Gates, she's only one of 4 obstetric and gynecologists, highlighting both the need and the emerging opportunities in this incredibly important area. Today, she'll highlight her work at the Gates Foundation and entitled Global Priorities in Reproductive Health Technologies. I just wanted to welcome Dr. Moley to Stanford and to this 4th annual research symposium. Dr. Moley.
Thank you. Thank you very much, Tony, for that introduction. And I don't want to take credit for changing the world, but I appreciate your enthusiasm for our work. And I think just want to say we are a team. It's not just me. There are many other non-OBGYNs that are working in this field as well. Next slide. I'm just going to preface this by saying that I am in Seattle and there have been storms the last 2 days and many trees are down, and I have, if I lose power, I'll go to my phone, but I've got my slides, given them to Grant so he can run the show. So this slide sort of starts off the conversation that we at the Gates Foundation are impatient optimists working to reduce inequity around the world. And we think the world's biggest problems can be solved, but we have a sense of urgency and impatience to solve them. Next slide. There are 3 things that help explain what make us unique and why we choose to take on the challenges we take on. First and foremost is we focus on areas of greatest need. We work to address gaps in health, economic opportunity, and education, where we believe to have the greatest effect. To tackle these big challenges, we work with partners who have the expertise and experience to develop and implement sustainable long-term solutions at scale. We also collaborate with governments, the private sector, and other funders to ensure the best possible alignment to fill these critical gaps. Next slide. Second, we take risks that others can't or won't. We look for opportunities to serve as a catalyst, bringing together the public and private sectors and civil society to address challenges standing in the way of a better life for the world's poorest people. We have the ability to apply new thinking to big problems, which sometimes means taking calculated risks on promising ideas. And we accept risks and failure as part of this process. Next slide. And finally, third, we make markets work for the poor. Philanthropy can be a powerful way to ensure all people can benefit from advances in health and economic development. Using innovative financing mechanisms and guarantees, we work with the private sector to ease bottlenecks in the development and delivery of low-cost vaccines, drugs, and diagnostics, to reduce the burden of infectious diseases in poor countries, or to reach women with the tools and technologies that enable them to thrive. We also invest in innovation and accelerate the development of proven technology solutions that improve teaching and learning. Next slide. The scope of our work is vast. We work across a broad range of issues, but all of them focused on removing the barriers that prevent people from living healthy and productive lives. For more than 20 years, we've learned several valuable lessons about how to tackle inequities as a foundation, and our approach continues to evolve based on new evidence and changing circumstances facing the world. As you see here, we gave out $5.1 billion in 2019 in grants. This year it is 7.2. We serve 135 countries and gave out close to 1,900 grants, more than the number of people that actually manage them. To bring about the kinds of changes that will help people live healthier and more productive lives, we seek to understand the world's inequities, whether the challenge is a low yield crop in Africa or low graduation rates in Los Angeles. We listen and learn so we can identify pressing problems that get too little attention. We then consider whether we can make a meaningful difference with our influence and our investments, whether it is a grant or a contract. All of our strategies, more than 24 across the foundation, have emerged through this process of identifying what we want to accomplish for people and where we can have the greatest impact. Once we commit to an area of need, we define our major goals and identify a clear path to achieve them. Next slide. So what do we do? Our missions bring the strands of the foundation's work together and explain how we will achieve our vision. We hope to ensure more children and young people survive and thrive. We believe the path out of poverty begins when the next generation can access quality healthcare and great education. We want to empower the poorest, especially women and girls, to transform their lives. We believe that by giving people the tools to lead healthy and productive lives, we can help them lift themselves out of poverty. We want to combat infectious diseases that particularly affect the poorest. We believe we can save lives by delivering the latest in science and technology to those with the greatest needs. And finally, we want to inspire people to take action to change the world. We know our resources alone are not enough, so we work to change public policies, attitudes, and behaviors to improve lives. Next slide. Several years ago now, the foundation began pivoting towards equity and specifically gender equality. This swell started by the urging of Melinda to put girls and women at the center of development to empower them to transform their societies. As Melinda states in her book, The Moment of Lift, understanding this link between women's empowerment and the wealth and health of societies is critical for humanity. She goes on to say that as women gain rights, families flourish, as do societies. And women's empowerment in societies help lift women and therefore nations. Next slide. Some of the inequities in sexual and reproductive health are due to culture, religion, and lifestyle. But we also believe that serious lack of investment in biomedical interventions in sexual and reproductive health is responsible for a large proportion of this inequity. As you can see here, these problems are quite vast, covering things from non-hormonal contraceptives, vaginal microbiome, HPV or human papillomavirus, syphilis, other STIs, and menstrual health. Next slide. But as I said, there's poor investment in public and private sectors. Women's health research funding makes up 1.2% of the overall NIH investment dollars, with 50% of this focused on cancer. Similarly, in pharma, R&D is spent on women's health is extremely low at 7%, and greater than 80% is on cancer. Next slide. So reproductive health technologies evolved from this desire to drive innovation specifically in sexual and reproductive health, to dramatically alter and improve women's health and well-being. The RHT portfolio aims to holistically consider the sexual and reproductive needs of women in low and middle income countries by investing in biomedical technologies that could redefine the care paradigm and improve women's lives and well-being. As you can see here, the main goals of our investments or grants are something to have a transformative impact on their lives. Second, to redefine the care paradigm for women. And finally, to really increase awareness of the importance and the neglect so far in R&D for sexual and reproductive health. And biomedical tools, just to say, are one part of the larger picture, but the one that reproductive health technologies is dedicated towards. Next slide. So RHT was launched, as it says here, from a larger division at the foundation called Discovery and Translational Science for the purpose of investing in biomedical technologies. And these are the main initiatives that will be covered by reproductive health over the next 10 years. 2 of these initiatives were already well underway. That is the non-hormonal contraceptive technology, as well as the vaginal microbiome intervention work. We added 2 new major primary initiatives, one being a secondary cervical cancer prevention vaccine, as well as data collection. And finally, 3 exploratory initiatives, one searching for HPV therapeutics, adequate menstrual health products, and finally, a prophylactic syphilis vaccine. And I will go through each of these individually just to give you an idea of what we are studying and following. Next slide. So, non-hormonal contraceptive. We know that unintended pregnancies are high all over the world, but specifically in low and middle income countries. And so we've made great investments in the basic biology in an early discovery phase around druggable targets that we can find. And using these modeled complex reproductive biology systems among several different universities around the world, we are looking to collect data on well-validated and tractable targets for further exploration at every point in the reproductive tract. Next slide. Our drug discovery approach is quite logical. Again, taking a new perspective, but yes, yet using similar past perspectives. Pharma in general, as I said, has moved away from the area of contraceptive research. And so we've conducted a thorough analysis of possible non-hormonal drug targets that are believed to be critical in the biological role of reproduction, paying particular attention to those that we could potentiate for safe and effective modulation. Ideally, we focus on targets where we could have a link to known infertility in women without other significant liabilities. As a first step, we've used computational analysis to assess a subset of the identified targets where we think we can have an impact. Overall, this will help us develop a holistic and rigorous approach of potential drug targets for contraception and to identify new opportunities to grow and expand the field of research. Next slide. Bacterial vaginosis is our next area of interest. And the reason for this is it's the most common vaginal infection in the world. 1 out of 4 women. It's a terrible infection, uncomfortable, malodorous, and really affects the lives of these women. Unfortunately, treatment with antibiotics is relatively ineffective and recurrence rates are high. Next slide. But the most important thing about bacterial vaginosis is what it leads to and what it's been associated with, and that is preterm birth, stillbirths, and miscarriage, as well as increased acquisition of HIV and more rapid progression of HPV to cervical cancer. And finally, it increases the risks of STI and infertility. This one infection has large-ranging effects on maternal and child health and is our main target of our research. We do know that one potential treatment of vaginal dysbiosis is vaginal microbiome transfer. And in a study that appeared in the New England Journal of Medicine in 2019, they showed that transferring vaginal microbiome from someone with a favorable microbiota into a woman with unfavorable appeared to be the most effective treatment and was sustainable. Next slide. So with that in mind, our work to date has focused on investing in the fundamental underlying science, including comparative microbiology, metagenomic, chemical, biological, and immunological characterization of stable, non-inflammatory microbiomes versus unstable and inflammatory microbiomes. Data integration is also used in the development of key in silico and in vivo tools for interrogating the vaginal microbiome dynamics and redefining an optimal live bacterial product consortia. As you can see here, we have funded several investigators, one of which is who's from Stanford, David Relman, to assist in leading this work. And we are working to define an optimal path for a non-antibiotic ecological niche opening to ensure stable colonization and biomarker definition. Next slide. The objective of our microbiome initiative is to develop an efficacious, scalable, deliverable vaginal microbiome that can treat dysbiosis and bacterial vaginosis, and with the end game of optimizing birth outcomes, preventing HIV acquisition and HPV progression. As we move towards first-in-human experimental medicine studies for vaginal microbiome interventions, critical issues include the optimal live bacterial product consortia for these experimental medicine studies, the optimal path for live bacterial product production and formulation, and the expansion of target geography microbiome partners, as well as the clinical trial strategy for these studies. Next slide. So the general strategy for forming this consortia is to actually collect, as they did in the vaginal microbiome transfer studies, stable L. crispatus or Lactobacillus crispatus microbiomes from women, and then combining those into a consortia that we could then potentially transfer into women with dysbiosis. Key resources, as you see here, are extensive observations, finding the optimal combination of consortia to cover the breadth of the metagenomics of Lactobacillus crispatus. Next slide. And this is just our strategy. We call it our weed, seed, and feed, akin to the old, I can't even remember the advertisement for, I think it was Scott's fertilizer. But that's what we're trying to do. We hope to clear out the current dysbiotic infections or pathogens with narrow spectrum antibiotics, hopefully moving this to antimicrobial peptides and avoiding bacteria or antibiotics altogether. We then hope to transfer multiple consortia of L. crispatus strains, and finally feed them with carbon sources and nitrogen sources to allow successful engraftment. And in a formulation we haven't, that we're working on to make this an optimal environment. So that is our goal. And here's an overview, next slide, of the current thinking around the proof of principle first-in-human clinical trial design, which is still evolving. The overall goal is to simplify and operationalize this, and these studies will be done in patients and treatment schemes with the best chance of success, with heavy biomarker sampling to confirm in vitro hypotheses and optimized models. These studies will be done in North America as well as Africa, and several sites have been identified. The study will initially be conducted in HIV uninfected premenopausal women with clinical bacterial vaginosis. We're then moving on to pregnant women and HIV positive women. Next slide. Moving on, so our second initiative is around a secondary cervical cancer prevention vaccine. And you may ask, well, there already is an HPV vaccine. Well, that is a prophylactic vaccine. It is really only applicable to women who have not seen HPV, and that's why it's given to adolescent girls. But that leaves all the women in the world who have been exposed to HPV that will not be treated by this prophylactic vaccine. And we, as well as others, have modeled the current trend of cervical cancer identification and have identified somewhere between 30 and 44 million women over the next 50 years will be diagnosed with cervical cancer. All of these, or the majority, are in low and middle income countries, and almost all are caused by HPV. So our idea would be to create a better tool for these women and transform the HPV care paradigm. And the idea here is that we could treat women who had not received the prophylactic vaccine and stop infection and prevent progression to cervical cancer. HPV is an infection that in most women is cleared by self-immune systems. However, in many cases, this goes on to progress and can still regress even after reaching a precancerous state. And this vaccine we'd envision would be a mass delivery cervical cancer vaccine to all women 25 and above in low and middle income countries. Next slide. This is a busy slide, but it's just to show you the difficulty that face women in these countries. In high-income countries, it's easy to be screened by pap smear, be tested, and then be treated. And in many cases, the treatment is just to return in a year. This is impossible. There are no well women clinics in low and middle income countries. And as you can see, going across from the different paradigms that exist in high income countries and in some areas in low and middle income countries, it requires several visits of a woman to a doctor. And so we feel over on the right-hand side that the greatest impact would be with a population-based vaccine, again, having a transformative impact and the highest patient intake with a minor funnel dropout in this diagram. Next slide. We predict that such a tool would obviate or eliminate screen and treat and would lead to a reduction in cervical cancer deaths, somewhere between 5 to 6 million. So what's different about our current approach? There are other therapeutic vaccines out there that are in trials now, but they are attempting to treat cervical precancer, CIN3. But our vaccine is designed to attack infected cells before transformation and clearance of high-risk HPV subtypes. What's different and why do we think this will work now? Well, over this last several years, as we know, many novel vaccine technologies have been discovered with transformative potential. And it's these platforms that we're using to create this vaccine. And finally, at the foundation, we plan all of our technologies with end-to-end in mind, working with WHO at the one end of the system, as well as with the scientists, and creating a vaccine that would be biologically relevant to our conditions. And with this ecosystem, we hope to foster faster and sustainable adoption in our geographies. Next slide. Moving on to menstrual health products. So many of us take this take advantage of this, having pads and other products available at all times. But in most of these areas, there's a lack of access to safe and affordable menstrual health products. And it's having a large impact on lives of women in these countries. Majority of these women have no access to adequate sanitation and water outside the home. And many women resort to using homemade cloth, which can be messy with frequent leakage and also is unhygienic. And this leads to further feelings of embarrassment and shame in many cultures and for this natural biological process. Next slide. And this is just showing you how women manage their menstrual health in other countries. And I don't want to read all this for you, but having to use all kinds of different articles, including cow patties, goat skin, using cloth, and some resorting to sitting on a hole in the ground for a week. This is terrible and really untenable for society, and especially for women. Next slide. And so our goal, keep going, next slide. Thank you. This is the slide, sorry. I wasn't watching slides. Okay, next slide. So our approach to menstrual health has been to reach out to material scientists in adjacent fields and also medicinal chemists, with the idea that we could come up with a technology that would really empower women, but also meet their needs. One idea that we've had is a drug that would cause amenorrhea, and several of the drugs that we have for contraceptives induce amenorrhea. But in many cultures, this is not an option. So the other is to create pads that would be sustainable, affordable, and increased absorption. And we are in fact working with Manu Prakash at Stanford University in creating a new model transformative menstrual health pad that can be produced locally and sustainably in their societies. And this is something we're very excited about and working with Manu and his students on. Next slide. So syphilis. Syphilis is one of the oldest infections in the world, and one that we still struggle with, believe it or not, in low and middle income countries. There is a treatment, obviously, penicillin, BPG, but the the distribution of penicillin is not readily available in many of these low and middle income countries. And as a result, there are 5.6 million cases each year, most of these occurring in the developing world. And of those 5.6, 1 million are among pregnant women. And this leads to maternal mother-to-child transfer. And as you can see, this leads to significant disabilities that are lifelong. Congenital syphilis, as you can see, over 500,000 cases in 2016, and this is rising. And we have an unknown number of stillbirths. The recorded are 200,000, but we know this is much higher, and we are attempting to get more information and data on this as we go in this process. And interestingly, syphilis also increases the rate of HIV acquisition. Again, another burden in these women's lives. Next slide. As I said, the current technologies for treating syphilis are effective, but due to poor enforcement, rapid diagnostic tests not being available, and again, as I said, stillbirths not being recorded, there's a lot of, as you can see, other issues here. There's a lot of barriers to treating syphilis. And we felt after assessing this, that a vaccine would be the best to address insufficient coverage in the screening and treating of syphilis. Next slide. So this is a very nascent field. There have been several researchers over the last years that have made some formative discoveries, but that's really been since the discovery of culture systems to grow syphilis. So this is very new, and we are working with key players around the world to determine the genetic diversity and the breadth of diversity of the outer membrane proteins to which we think these vaccines need to be made. So in our discovery phase, we're looking for immunogens and collecting genomes from all over the world with different strains in order to create a pan vaccine global. Next slide. And finally, the crux of the problem is the lack of data. It's amazing how little we know about sexual and reproductive health overall, especially in low and middle income countries. And so we are seeking ways to collect this data on a population-based basis with epidemiologists at the foundation. Not only do we need to know about disease burden, but we need to know user needs and preferences for many of the products and tools that we're making. Gone are the days of us creating a vaccine or creating a technology and then delivering it. We now understand that we need to do this in country and create most of these technologies to be transferred there, but also hopefully to be sustainably produced there in the future. And to do this, we also need to know the user's needs and preferences, what they want and what they expect in these products. And finally, the big elephant in the room is the males and how we can prevent partner reinfection. This is a much harder nut to crack, as I've realized. And we're working on ways to decrease barriers so we can really engage partners in preventing sexual and reproductive health issues. Next slide. So this is my final slide, and we at the foundation are really dedicated to women and to men and to women and men. But in this sense, my portfolio is around reproductive health. And we envision a world where every person has the opportunity to live a healthy and productive life. And I thank you for inviting me. It's been a pleasure, and I'm happy to answer any questions. Thanks.
Great. Thank you so much, Dr. Moley, for that really stimulating and a really visionary presentation. I just want to have a couple of questions from the question and answer period that we can discuss. I think the first question is, can you elaborate on your goal of making markets work for the poor? As this is a major difference between NIH funding, which we're little with the markets, and industry, which markets for those that pay, and how you can bend the curve. I think that's one of the unique aspects of what you're trying to do. Can you elaborate more on that?
Yeah, it basically has to do with our relationship with the small startup companies and larger companies that we work with. I'd say probably from what I know, and again, I've only been here for about a year and a half now, the vast majority of our grants are not to academia. They're just small startups or businesses. And for these, we are hoping by having them sign our global access and our humanitarian license, that they will produce with our funds technologies that can be transportable and affordable for people in these countries. And that is, in smaller startups, we will give investment and equity in companies in order to help them grow and to do this, but with the understanding that the ultimate product that they create will be made available. And this has been, that's been the goal from the beginning of the foundation, really forcing affordable healthcare products for the less fortunate.
Right.
I think that's basically, it's an equity investments that we make in different companies, as well as the grant funding.
Right. I think that's really what the unique aspect of where the foundation goes between the NIH and industry, because that's the part that actually is the hardest to actually get, which is that bending the market so that people can get it in the underserved areas. So that's really amazing. Next question is
also de-risking. So a lot of these inventions and ideas really are not going to be picked up from pharma unless they are de-risked. So I think that's that valley of death that we're really trying to close.
Right. And do you think by doing that, then you mentioned that there's only 7% of investment in pharma is in this area. Do you think then that one of the growth output, the markers then will be to have it be wider because of that?
That's what we're hoping. Yes.
Right. Awesome. So next question is, what can researchers at Stanford get involved, or how can they get involved in helping to contribute to these issues in young girls and women?
It's a big question. We spent a lot of time yesterday talking about with the larger group. I think better communication between us and you as far as things that we would be interested in looking at. As I said in the presentation, we are an organization of about 1,600 people. Most of us have either been in academia or pharma, and have come there to do the mission. And to do this, I think we come up with strategies and ideas. And rather than calling, calls for grants, which are very rare and are probably the least funded of all the funding that we give out, we seek out people who we find in the literature are doing the best work. And I think better communication, we could communicate with you, you could communicate with us, but for us to let you know what we are looking for. And hopefully this discussion has kind of enlightened you as well.
And I'll just tell you that from the leadership, it really has. And we really appreciate the insights you provided yesterday, because I think that communication makes us know what is needed, what technologies and how and what form it's needed. And then it allows you to know sort of and work together, like, for example, with Dr. Prakesh's that you mentioned in your talk. Another question is, congratulations on your very coherent, compelling strategy you outlined. In what ways do considerations of gender, for example, power dynamics, enter into the things that you're doing?
Yeah. So reproductive health technologies is really under discovery and translational science. I am a physician scientist for life, and that's sort of my training. There are other branches of the foundation that focus on empowering women through economic advances, leadership training, education, as well as digital access. There's a whole department, if you will, of gender equality that just was started in November of last year, led by Anita Zaidi. And we work closely with her. We're creating the tools for her to then use and apply, but she also has many behavioral and social levers that she's using to advance women's empowerment.
Wonderful. And then also one of the rate limiting steps in terms of understanding and getting data, because one of the things you talked about is data. What are your thoughts in terms of where are the technologies or what's needed in terms of getting additional data from either from women or pregnant women in the field? I think some of the things you'll hear about in the next session what it leads to that, but I was just wondering your thoughts in terms of where are the major data acquisition roadblocks that would actually really unlock things for these issues.
Yeah, I think a lot of the problems around women's health, as I alluded to a little bit, was that there are no well woman visits. There are no touch points in women's lives except when they're pregnant. And that seems to be a time when we can, they have to come in for medical assistance. But so trying to figure out data or disease prevalence, you're also limited to sexually transmitted clinics, STI clinics. And getting access to those for collecting data, and more importantly, to knowing where the academic centers are that are doing great research in pediatrics and also in obstetrics. I think those are also important data points. As I said, we're trying to build capacity in these countries for biomedical research, as well as, so not only are we introducing tools to them, but we're hoping that they can further develop those tools or learn from us how to create these tools in their own geographies. This is a lofty goal, but one that we're committed to over the next 25 years.
Right. And then just one last question. I think one of the surprising things that you mentioned was how few people are really like you working in this area. So in terms of a training aspect, that's one of the things that we really love to do is train. How can we train people or suggestions for training folks to basically do what you do in a better way? Any thoughts on how to do that better? Because clearly there are not that many people doing this.
No. There's a lot of answers to that question, but I think for me, it was a matter of applying for a job that I really never would have assumed I would be applying for 10 years before. I was on an academic reproductive health track and saw myself as a department chairman somewhere.
Right.
But I think at some point in your life you have to reconsider where you're going and if it's where you really want to go. And I think at that point, I wouldn't have at 25 decided I wanted to go work for the Gates Foundation. I think you have to go through your life experiences and your background to get there. So I just would leave the door open and the option open for considering philanthropy and foundation in your future career. As an OBGYN, I really felt like I was making formative discoveries in my lab, but in the end, I wanted something more. And I would like to do something that I felt had more impact. And I think if that's what drives you, then definitely think about foundation work, nonprofit work. But that's, a personal decision.
Yeah.
I think the options are out there. It's just, again, women's health, even child health has been neglected in many ways in biomedical interventions. So this is a new territory for us, but I think it's ripe for more maternal child health people to go into.
Right. And also one of the reasons why we wanted you to speak is because as a role model, I think you really epitomize that kind of, 3R1's lab and then moving towards the foundations. And so I think that's really a wonderful thing. A question just popped in. Can you explain more about the vision between sexual reproductive health and the health of the newborn? And really what are the ways we can further identify these health issues, the impact of them and how to mitigate them?
Yeah, the connection between the two is very clear. I think the vaginal health in particular is critical for successful pregnancies. And I think that my whole portfolio revolves around reproductive tract, but really about genital health. And this is just something that, even here in the US, we're not really thinking about, but it's something that's, critical for child development. Most of the causes of, like I said, stillbirth are thought to be infections, specifically syphilis. And the same with all the other non or inflammatory STIs. So gonorrhea, herpes, these are things that really need to be taken care of prior to pregnancy, or at least identified.
Right.
Otherwise, there are significant outcomes for babies. But even more nutrition and environment of these women, and the way that they are, their microbiomes are living in their gut. It's not just the vaginal, it's also the gut microbiome. So there's, by nature, a closeness of how those two things really affect fetal outcome. So the two go together in my mind always. And even, up until, gosh, I've got 30-year-old sons. they're still relying on me. But I think, even early on, you have to be able to dynamically, obtain eubiosis, if you will, in different compartments so that the mom can have a healthy baby. Right.
I think that's one of the surprising things that come to our viewers, is that there's this critical interplay between maternal health and child health. I think that really is nothing else from today. I hope that's what the listeners will get out of your talk. Last question. I think we have a couple more time for questions. Are there, I know we talked yesterday about efforts to repurpose existing therapeutics that are often off patent or that are at low cost. Can you describe some of those successes that or some of the things you're thinking about for reproductive health?
Yes, the thing that the non-hormonal contraceptive work, we are definitely using caliber, other sources of drug libraries to repurpose, and looking for them, running them through our high throughput technologies and assays in both sperm and egg development, as well as urine receptivity. So definitely we are repurposing drugs for looking for non-hormonal contraceptives. The other is around the bleeding that's associated with the current progestin-only contraceptives. This is a huge problem in lots of places, and the cause for discontinuation of use, and the whole reason that we're going to look for a non-hormonal contraception. So we are looking for adjunct therapies that could prevent bleeding. Probably this is related to estrogen and progesterone receptor inhibitors or modulators. So we are screening and looking for drugs that are already existing for these purposes. I think that's probably, an antiviral for HPV would be another consideration. That is in our portfolio. I didn't talk about that today, but we are looking for potential antivirals to use for HPV infection.
That would be amazing. And then kind of a throwback question. What about, I know you're an expert in maternal obesity and diabetes. So is there any that part of it in your portfolio, or is that in the past?
Unfortunately, that's all in the past. I think nutrition is key. Right. Maternal nutrition. And we are thinking about the microbiome, the gut microbiome, and how it affects the fetal outcomes. So that's about as close as I get. That's past life, but very important, obviously.
And does maternal nutrition also regulate the vaginal microbiome as well?
That's what we're trying to figure out. Yes, I anticipate that it does. I definitely think the gut microbiome, as we know, signals many other organ systems in the body. We just want to make sure that our vaginal product is not interfering with that connection and that relationship. But yes, no, we definitely think maternal nutrition is affecting vaginal health in general.
Wonderful. All right. I think we have time for one more question. And this is a great one. What do you find most fulfilling in your current role? You've done so many things: academic, National Academy member, which it's a tough decision, but what do you consider the most rewarding part of your career?
I think, the job I have now is quite rewarding. Because of COVID, I have not been yet to these territories that we're treating and talking to. Luckily, with Zoom and Microsoft Teams is what we use at the Gates Foundation. I'm able to contact and be with many of them. And I think what's most rewarding is hearing, especially from the providers, the obstetrician gynecologists, the healthcare providers, just the incredible, hope that they have, thinking that women's health would be something that would be addressable and that would be doable, and that we're actually interested in creating technologies for this. I mean, It blows them away, especially around menstrual health. That is just horrific. I mean, I feel such, a commitment to really find a solution for them that's going to work and not hinder their lives and tax them for a biological process that, right now there are over 500 million people in this country or in this world menstruating. How come we don't have adequate menstrual health products? I mean, it doesn't make any sense, right?
Right.
So I think the brevity and the breadth of everything that's possible that you can try, and really being at the foundation is a blessing. There's just a lot of opportunities, just directing them into the right areas.
Right. Well, if we could bottle that inspiration, that passion, and then sprinkle it on all of our academic folks here at Stanford, I think maternal health would actually be an amazing change. And so we just wanted to thank you. We could talk to you all day, Dr. Moley, but unfortunately we have to move on. We want to thank you so much on behalf of the Education Committee of the MCHRI and all of the Stanford community and leadership. I think your inspirational talk, and we're really looking forward to the next few years of how you're going to be transforming maternal health at Stanford. And so thank you again for joining us, and again for the nice questions from the community. So thanks again.
Thank you. It's my pleasure, and it's amazing to hear how much work and how much progress you've already made in the MCHRI. Thanks.